I made a little modification to my topic because of the time limitation. I think the management of arthritis and stiffness is too big for me. And today I'll just talk about the arthroscopic management of stiff elbow. Actually, included some arthritis. Elbow stiffness usually comes from the trauma and arthritis. In my practice, most traumatic stiffness, post-traumatic stiffness is the most common. So what causes the stiffness? We can always find the soft tissue or bone problem. So my topic will divide to two parts. The first part is soft tissue problem, which mainly include capsule, ligament, and muscle. And the pathologic change of this soft tissue is contraction and adhesion. So the capsule contraction is most common in stiff elbow, or almost every stiff elbow. And the technique of arthroscopic capsule have been well described by many people, like Dr. Savard. The capsule adhesion may occur when there is intra-articular lesion. That will make the arthroscopic procedure much more challenging. The second soft tissue may contribute to stiffness, the ligament. Posterior bundle of MCL contracture is very common in extension stiffness, and adhesion can happen between annular ligament and the radial head, and the collateral ligament to the condyle. This young lady comes with the elbow stiffness 4 months after trauma. She has very limited elbow flexion and ulnar nerve symptom, and there is ossification in the origin of the posterior bundle of MCL, which is a clue for ligament contraction. We did arthroscopic release. This is a posterior medial aspect of the elbow joint. I released the posterior capsule and the MCL as well as the HO. And this is 1 week after the surgery. And we can see the HO is already cleaned up. In my practice, adhesion between annular ligament and the radial head is more common than collateral ligament to epicondyle. And this lady is a surgical treatment terrible trial. She comes with very limited elbow motion and forearm rotation. We can see HO and the fracture fragment in front of the radial head. Anterior compartment is debrided and the annular ligament was released, and the heterotopic bone and the fracture fragment was removed through this approach. We can see there's quite a severe scar tissue between the actually surrounded the HO and the fragment. The ligament is just adhesion to the whole bone structure, including the radial head and the HO. After exercise release and exercise, the annular ligament, the HO can be removed through this approach. This is a passive motion release. Both the elbow flexion and the forearm rotation is restored. She got quite a good elbow motion and at 10 weeks after the surgery. And the forearm rotation is keep improved. And there's no actual occurrence in the CT scan follow-up. The third soft tissue contributor to stiffness is the muscle. It also can be contraction or adhesion to the bone. Most common in my practice is triceps to distal humerus. This is a stiff surgical treatment of distal humerus fracture. Triceps was released from the distal humera and the plate. And the posterior bundle of the MCL is also released. Of course, the posterior capsulectomy is also performed through this approach. Yeah, we can see the posterior bundle of the MCL. So resect. If there is a persistent stiffness, the plate can be removed, especially the posterior lateral plate, because this plate sometimes have the adhesion between this plate and the tricep. The ulnar nerve should be exposed. The medial plate needs to be removed. The ulnar nerve should be exposed and under protection. This is a 2 months follow-up with good range of motion after surgery. Muscle contraction is not common and usually need open surgery. We won't discuss in this talk. So bone problem of elbow stiffness include osteophyte, HO, articular deformity, and damaged joint. And arthroscopic treatment can be used for osteophyte, HO, and articular deformity. The damaged joint usually need an open procedure for arthroplasty. Osteophyte is a typical change in osteoarthritis. It can be occurring fossa chronoid or chrono, and usually the whole periarticular area. The ideal treatment is to remove all the osteophytes which impairs motion, which can be done arthroscopically. Usually all the impingement can be resolved through by using burr and curette. Yeah, it's a lot of work because the osteophyte is all around the joint, the periarticular joint. The second bone change in stiff elbow is heterotopic bone, which is very common in post-traumatic stiffness. There are several classifications mainly focused on the size and function. Most famous is from Hale Hastings. But for arthroscopic treatment management, the location of the HO is also very important. There are several special locations may change the approach for arthroscopic release. Once the HO is close to nerve, ligament, and tendon, and the articular surface, will make the arthroscopic procedure very challenging and high risk. According to the real situation, the surgical approach can be all arthroscopically or combined with open incision, or even staged surgery, which is described by Shaw and Driscoll. Arthroscopic removal of HO is relatively easy when the HO located in safe area or in early stage. I think Dr. Sava have well described the very good results by early remove the HO in the early stage. For example, this is the heterotopic in anterior and the posterior aspect of this. We can see this HO can block the elbow motion, anterior and posterior. And so this, although this HO is not small, but it can be removed or under a scope because this HO is in a relatively safe area. There's no nerve, ligament, and tendon. It's anterior to the HO is brachialis muscle. But we really need to make a very smooth surface in the distal humerus after resection of the HO. This is CT scan compares the pre-operative and the post-operative HO. This is functional recovery after surgery. Of course, the soft tissue release is also very important beside the HO removal. The second option for HO removal is a combined approach, which is combined using of arthroscopic technique and open approach. It is usually applied when there is extensive HO and HO in risk area. This stiff elbow is 9 months after trauma. There's extensive HO in the posterior aspect of elbow. And the HO is very close to the origin of the LCL and the ulnar nerve. We remove the HO through posterior medial approach and perform the ulnar nerve decompression with, by using the same approach. The range of motion after HO removal. And then we perform arthroscopic release in the anterior compartment. The HO from the LCL was very close to the LCL. It can be removed by using burr and a curette. And we can see the LCL can be well protected because those instruments is very safe. This is the range of motion after we try to check the stability at the end. Yeah, sometimes because the HO is very close to the ligament, so we worry about the stability after HO removal. So this is the functional recovery. It's 7 weeks after surgery, and there's no HO recurrence from the CT scan. The third bone problem contributed to elbow stiffness, articular deformity. Arthroscopic osteoplasty can be performed if the deformity is irreducible due to the long history, especially underwent growth, or there is a very complex fracture malunion. This technique is similar to the HO removal. So a brief summary for arthroscopic treatment for steel elbow, we really need to recognize the major problem which causes the stiffness, then apply appropriate approach with open or arthroscopic technique. Thank you.
Thank you, Dr. Lu. Thanks for your comprehensive and excellent presentation. So after all this scope, and Dr. Sugaya Hiroyuki would like to talk on the staying safe in elbow arthroscopy. Thank you, Dr. Sugaya.